This week on the BackTable podcast.
I would say there's a lot of variability in clinical practice on what materials are used to embolize. Some people use coils only. Some people use coils and gel foam. Some people use sclerosant. Some people use coils and sclerosant. There's a lot of variability. And I think as long as you are able to completely obliterate the left gonadal vein and prevent its reflux and treat all of its collaterals or duplications, then I think you've provided a satisfactory treatment.
Welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a quick word from our sponsor.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast. Now, back to the episode.
I'm your host, Dr. Baheti, coming to you from Tacoma, Washington. My guest today is Dr. John Mattson. He is an assistant professor of interventional radiology at the University of Virginia, which is a super fantastic place to practice IR. And our topic today is varicocele embolization. John, thanks so much for coming on the show.
Absolutely. Thanks for having me.
Okay, well, this is kind of a bread and butter topic in IR, so we're not going to get too crazy, but I'm excited to learn about how you like to do the procedure and kind of some tips and tricks for folks who are getting started. Let's start out with the basics. What are the indications for a varicocele embolization?
Yeah, that's awesome. I think one of the most important parts of treating patients with varicoceles is inviting them into the clinic and having a pre-procedure evaluation. So since COVID, we have in my clinic rapidly and extensively expanded our telehealth visits. But I think it's important to have an in-person and face-to-face meeting with the patients in order to find out if they have a varicocele, how significant the varicocele is, and how important it is to treat it. And so I treat male varicoceles for patients who have clinical symptoms, which include palpable varicocele pain and abnormal semen parameters that lead to infertility.
Okay. Are there any imaging findings that you have to have before you'll treat somebody?
Typically, I start with a physical exam, and that includes a standing evaluation with and without Valsalva to see if I can visualize or palpate the varicocele. But then I also couple that with an ultrasound evaluation. So need to see a dilated venous tympaniform plexus greater than 2 millimeters, and then typically reflux within the tympaniform plexus with Valsalva.
Okay. You get an ultrasound for everybody before your clinic visit, or is that something you might get afterwards if you had a question?
In general, when the patients are referred to me for this procedure or this evaluation, they have already been diagnosed with a varicocele by someone else, and I typically get an ultrasound if it hasn't already been performed, and they get that before seeing me in clinic so I can review in clinic with them.
Okay. Tell me about the semen parameters that help define a varicocele.
Typically, those are worked up more by the urology folks before they come to see me, I have to admit. But male infertility, male infertility with a normal female fertility in the partner couple and inability to conceive is typically what I have used as a criteria.
Are most of your patients reproductive age males, or do you see some older guys too?
I would say the majority of the ones that I have treated are reproductive age males, and the indication has been primarily for fertility issues, although I have treated older men with pain.
Okay. Any other indications for varicocele embolization that we should be aware of?
I would say in pediatric patients who have testicular atrophy and a varicocele, we can also treat them.
How about contraindications to the varicocele procedure?
But I guess one other indication would be failure of prior other management, maybe surgical management in addition. So if they've had a surgery and then continue to have symptomatic varicocele.
But how often do you see the failed surgical varicocele coming to you for an embolization?
I have not seen it very often. I've only treated in my 3 years of being out of training, only treated residual varicocele after surgical management one time. So not a very common indication, but an important one nonetheless.
Okay. Are there any contraindications that we should be aware of for varicocele embolization?
Not a lot of absolute contraindications to varicocele embolization. Generally, you have to be aware that if it's an isolated right-sided varicocele, that suggests that there could be some central obstruction on the right side, as right-sided isolated varicoceles are much more rare. So typically, if a patient comes to me with an isolated right-sided varicocele, rather than jumping to varicocele embolization, I will perform cross-sectional imaging of the abdomen, whether that's MRI or CT, to look for some sort of malignancy that might be causing the right-sided varicocele. In addition, other absolute contraindications are uncommon, something like coagulopathy that's uncorrectable or something along those lines.
All right. So walk me through kind of like what a clinic visit with you would be like with the patient. What do you talk to them about? What do you counsel them about? And then what do you give them about expectations for recovery and outcomes?
Yeah. So typically, I interview the patient and ask how they found to come to an interventional radiology clinic. It's somewhat unusual that patients refer themselves. Usually they're referred by someone else to my clinic. And I ask them how long their symptoms have been going on, what symptoms or awareness they have of their varicocele, and what, if anything, they've tried before to treat their varicocele. Typically that then also includes a physical exam with a standing evaluation if I can see or palpate their varicocele with or without Valsalva.
Okay. And then how do you talk them through what they're going to expect on the day of the procedure?
Like most of our interventional radiology procedures, we perform this exam with minimal, light, or moderate conscious sedation, which I've found in young, healthy, otherwise healthy men is sometimes a barrier. They sometimes tend to assume that they'll be put to sleep, but just sort of talking to them and talking to them, letting them know that they'll be comfortable and receive the amount of sedation they need to be comfortable, but not enough that they won't be able to follow instructions like take a deep breath in, hold your breath, perform a Valsalva. And just to let them know that the procedure probably takes somewhere on the order of an hour to 2 hours, and that they'll be watched in our recovery bay, but should be able to go home that same evening. And that unlikely to have significant pain that would require hospitalization overnight. And then I typically tell folks that they will be able to return to work the next day as long as their work doesn't involve any heavy lifting. And I typically use the suggestion that no lifting anything heavier than a gallon of milk for 48 hours and suggest that maybe their family member do all the grocery lifting.
So I don't know if like the gallon of milk is just a UVA thing, but I totally just use that for everything all the time too. Like for groin patients, if I tell them, oh, that you had an angiocele or you had a groin access, don't lift anything heavier than a gallon of milk for a week. I don't know. The gallon of milk like really resonates with people, I feel like.
It's so approachable. Everyone knows what a gallon of milk feels like. But I think you're right. It might be a UVA thing.
Okay. So that's kind of like the expectations for the patient. Now, walk me through your procedural setup that you like to do for a varicocele embolization.
Yeah, so you can access either from the groin or from the neck. I have done varicocele treatments from femoral vein or internal jugular vein access. I much prefer the right internal jugular vein as I think it allows for easy access into the left renal vein and into the right gonadal vein if necessary.
So how do you pick, like you don't get CT scans beforehand for these guys usually, right? So how do you pick like which way am I going to go?
I almost always go from the right internal jugular vein.
Cool. I want to know, how do you like to set up your table? What do you have open on the table beforehand? And then walk me through the procedure of how you do your varicocele embolization from start to finish.
Sure. So I typically start with a right IJ puncture under ultrasound. I use a 6 French sheath in order to get access from the right IJ. I usually use a 40 or 45 centimeter long sheath because I think that gives you access down into the left renal vein. Typically, the gonadal vein embolizations are performed on the left, but also can be done on the right. typically use a C2 catheter and a glide wire to easily select the left renal vein. If I'm having trouble selecting the left renal vein, sometimes I'll use a pigtail catheter to do a pigtail run of the cava, do a cavogram. And then you can put a tip deflecting wire in the pigtail catheter and use that to select the left renal vein. If there is abnormal left renal vein anatomy, that can be picked up most easily on the cavogram. And then once I have access into the left renal vein, I'll do a left renal venogram and look for reflux in the left gonadal vein, which typically comes off of the inferior margin of the left renal vein right at the level of the lateral margin of the vertebral body. Kind of helps you look for where to select it. Sometimes that same C2 catheter and glide wire can be used to point caudally and then kind of fall into the cranial aspect of the left gonadal vein. If I'm having trouble selecting the left gonadal vein, I'll sometimes switch my C2 catheter to just a vert or an MPA, which has a little bit gentler of a curve that can fall into that left gonadal vein. And then with the 5 French catheter in the left gonadal vein, I'll do a gentle hand injection, a hand DSA of the left gonadal vein, looking specifically for duplicated left gonadal veins, different collateral channels to paravertebral veins or other collateral veins associated with the left renal vein. And then also look for reflux down the left gonadal vein into the scrotal sac, into the pemphiform plexus. And you can do this same injection with and without Valsalva to prove the reflux and the incompetence of the left gonadal vein.
So now you're all set up, you're stable, you got your catheter in the left gonadal vein. You mentioned kind of you always start with IJ approach, but how long do you try from the IJ to get into the renal vein before you might switch to femoral? Or has that never happened? Like, do you always get it from the IJ?
I have never had to switch from IJ access to femoral access to perform the procedure. I have done gonadal vein selections from the femoral access, but I have not failed yet from the IJ access.
Yeah, but next week, I think, tell you.
Yeah, next week, of course, I'll probably have one and I'll fail. I think coming from the internal jugular vein allows for relatively smooth access, working caudally towards the left and into the gonadal vein. And it allows you to kind of position your sheath right at the origin of the left gonadal vein. So you have kind of a landmark under fluoro of how high up, how cranially up the gonadal vein goes.
All right. Okay. So now you're in the gonadal vein. You've proven that there's a varicocele. Tell me about how you size your coils and any other kind of embolics you use.
Yeah. So I'm on the left gonadal vein venogram, kind of magged out and viewing over the lower pelvis. I advance my catheter, either microcatheter or base catheter, down to the level of the inguinal ring, kind of at the level of the inguinal ligament over the acetabulum. And that's where I start to put my first coil pack there. And I like to oversize the coils that I use by at least 50%. And that way I'm trying to minimize the risk of this coil migrating either down into the pemphiform plexus or up into the renal vein. And then I've used a variety of coils here. The penumbra coils made of platinum are advantageous, but then I also like to use the Embolic coils as they're fibered. But for that first coil pack, oversized by about 50% right there at the inguinal ligament so that the patient hopefully won't feel the coil pack. I do a nice dense coil pack there. And then if I've seen lots of collaterals to maybe another gonadal vein or to paravertebral veins, then I will add either gel foam or gel foam mixed with Silterdecol.
Okay. So the liquid embolic, or I guess the gel foam Silterdecol thing, isn't a standard for you for varicoceles, which is a little bit different than kind of how we treat female gonadal vein reflux, you know?
Yes, I would say in female gonadal vein reflux or pelvic venous disease in women, always I would use a mixture of gel foam, Silterdecol, and Lipiodol to sclerose the pelvic varices. That's different in men, where I try really hard with my initial coil pack at the inguinal ligament to prevent the sclerosant from going down into the pemphiform plexus, as that can cause a significant amount of pain. and other venous ischemia of the testicles.
Okay. I'm assuming that's also the reason why you don't like to have coils below the inguinal ligament, correct?
Yes, that and because if you keep the coil pack above the inguinal ligament, then the patients won't necessarily feel the coils; they'll be in the pelvis.
Makes sense. Okay.
Yes.
And then how far up do you coil? Do you coil all the way back to the origin from the renal vein?
Ideally, I do a series of coil gel foam coil sandwiches all the way back up as close as I can get to the left renal vein origin or confluence of the gonadal vein and renal vein.
Okay.
If there are duplicated gonadal veins, I will coil back up to the confluence of the duplication and then select the other branch and then coil it as well.
All right. And does it ever happen where you coil the main branch, then you get back up, do your repeat venogram, and then you see new stuff pop up?
Yes, that's why at each level of the coil pack, right as you're about to inject gel foam, I try to do a little additional venogram and see for any additional veins that fill and kind of work your way up the gonadal vein in a stepwise fashion, doing venograms at each level, hopefully so that as soon as you see reflux into a collateral branch or a second gonadal vein, that you can address it.
Okay, yeah. No, that's really neat. Okay, so you finished doing your left gonadal vein embolization. Now what do you do?
Then I want to do a left renal vein venogram and ensure that there is no additional or collateral flow into the gonadal vein that I've embolized, no additional gonadal veins that have not been embolized, and that I haven't had any of my embolic reflux or fall into the left renal vein, which is sort of the feared complication while you're doing these embolizations.
Oh, sure. Yeah. Yeah. You know, like some folks use balloon occlusion to try and prevent the reflux. Do you find any utility in doing that, or have you had pretty good results just doing it with the 5 French catheter?
I would say that for, like you said, in women's gonadal vein embolization, I always use a balloon occlusion catheter. I use a 9mm Python balloon through which I can put my cantata microcatheter. But in men who, in my limited experience or in my experience, have not had quite as many collateral veins to duplicated gonadal veins, I've found that the gel foam, which I inject small amounts of and am less concerned about refluxing, I have not needed it. Although I would use that if I was really trying to fill different collateral branches to the vertebral veins or to other gonadal veins.
Okay, so tell me a little bit about complications from the procedure. What have you read about, and what are your most feared complications?
So my most feared complications would be non-target embolizations. So whether that's with my coils migrating peripherally into the pampiniform plexus or migrating proximally into the left renal vein, or worse, into the IVC and embolizing into the pulmonary arteries. And so I think sizing of your initial coils is very important. Most of the more senior faculty at my institution would use a lot of pushable coils. I will use some pushable coils, but I'll try to at least make my first coil pack a detachable coil, and then certainly my final coil pack at the origin of the left renal vein or left gonadal vein, where it meets the left renal vein, that certainly I'll use a detachable coil there also. That's probably my most feared complication. Also, if you're using a sclerosant like a Sotradecol foam, you run the risk of that embolizing up into your left renal vein and into the IVC. And so, like we said, a balloon occlusion catheter, like a Python balloon, can help force that sclerosant into the collateral veins rather than migrating up into the left renal vein. Other complications include perforation of the vein. So if you have your 5 French catheter and a glide wire and you're trying to select further down into the gonadal vein, you could injure or perforate the vein there. You could overpressurize it, especially if you're using your balloon occlusion, your occlusion balloon to kind of pack in sclerosant. You could overpressurize between your occlusion balloon and the coil pack and rupture the gonadal vein. So you have to be careful not to do that as well.
If that were to happen, what's kind of your next step other than call Dr. Engel? Just kidding.
I think I would continue to coil, and I would make sure that I have a nice dense coil pack there, and then do completion venograms there afterwards.
After you change your pants, yeah.
Making sure
just kidding.
Yeah, making sure there's no additional extra.
Cool. Okay, yeah, I think we pretty much covered the basics of the varicocele procedure. Do you know much about the surgical treatment for varicocele, what the urologists do?
I have to admit that I have not ever seen one. I know that the surgical treatments include a kind of sort of microsurgery down at the level or just below the inguinal ligament where they ligate the gonadal vein just as it exits the inguinal canal.
Okay. So they work way lower than us. Okay, I could see kind of why there could be failures from that. That makes sense. Okay, well, what do you do for follow-up for these patients?
Oh, yeah. So in general, I will discharge the patients same day after the procedure. I think it's particularly convenient if you've done an internal jugular vein access. Their bed rest is minimal. Typically discharge them with just a little bit of pain medication, a little bit of anti-nausea medication for a day or two, and then see them in clinic in about 6 weeks or so with a repeat ultrasound just to confirm resolution of the varicocele.
All right, yeah.
And then of course, no heavy lifting for 48 hours or so.
Cool. Anything else that our audience should know about varicocele embolizations?
I would say there's a lot of variability in clinical practice on what materials are used to embolize. Some people use coils only. Some people use coils and gel foam. Some people use sclerosant. Some people use coils and sclerosant. There's a lot of variability. And I think as long as you are able to completely obliterate the left gonadal vein and prevent its reflux and treat all of its collaterals or duplications, then I think you've provided a satisfactory treatment.
Awesome. Okay, Dr. Mattson, thank you so much for coming on the show.
Yeah, thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
And Ali Baheti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.